Good evening, myself Dr. Karthik. Welcome to our weekly webinar. I am consultant ER physician in Yashoda Malakpet. Today we are going to discuss about dengue fever and its management, which is very common and most important condition seen nowadays and more common in rainy seasons. Today I welcome Dr. Ranjith Kumar, consultant ER physician in Yashoda Somajiguda, to continue with that topic. Over to you, sir.
Good morning, everybody. Myself, Ranjith. Today, we are here to discuss about dengue fever and its management. So, coming to the topic. So, dengue fever occurs in almost 100 million cases annually, and nearly up to 25,000 deaths are noted across the world. So, it is prevalent in more than 100 countries. Asia, Africa, Australia, and America. So basically, the term dengue means sudden cramp-like seizure caused by an evil spirit. So that is the reason it is otherwise called breakbone fever or dandy fever. So dengue virus is part of a flavivirus family. So it has got 4 serotypes, 1, 2, 3, and 4. So the dengue virus can cause asymptomatic infection to severe potential life-threatening disease. So a total of dengue infection can occur 4 times over a lifetime, and there cannot be, one strain cannot cause infection twice. So more than one episode of dengue from these infections are possible. So each strain can lead to a lifelong type-specific immunity, but short-term cross-immunity occurs against other serotypes for about 2 to 6 months. So the primary host is usually the infected human. Secondary host being saliva of the female Aedes aegypti or Aedes albopictus mosquito. So the transmission is usually mosquito bite, or perinatal transmission is possible, blood transfusion, organ transplantation, theoretically, and needle stick as well. So the infectivity period is usually for about 7 days and can present 1 to 2 days before the symptom onset. The extrinsic and intrinsic incubation period is 8 to 12 days and 3 to 14 days respectively. So it cannot be transmitted by respiratory droplets or saliva or through sexual transmission. So perinatal transmission is possible from the vermic mother to the fetus in utero or even at the time of parturition. But the rates of transmission are still unknown. So basically, it depends on the severity of the maternal disease and timing of the infection. So coming to pathogenesis of dengue virus. So severe dengue patients, they is usually seen in patients with secondary dengue infections and infants with primary infections. Though the exact mechanism of pathophysiology, the cause of severe dengue is not known. It is mainly assumed to be due to the antibody-dependent enhancement. Others being neutralization and opsonization, and antibody-dependent cellular cytotoxicity. See, what happens is like the non-neutralizing heterotropic IgE dengue antibodies produced during a person's first infection, dengue infection, or subneutralizing antibodies in the case of an infant who acquired it through the in utero. It can form antibody complexes in the second infection. Then it leads to uptake of a dengue virus with macrophages, where it gets replicated and viral production is increased. So the virus is taken up by the antigen presenting cells, where the mature APCs enter the lymph node through lymphatics and produces chemical messengers that attract or activate the T cells, and they result in cytokine storm, like activated T cells resulting in production of TNF alpha, IL-6, IL-8, interferon gamma. So ultimately resulting in the plasma leakage through cell-cell junctions, which lead to loss of plasma and increased hematocrit, third phase loss, and shock. So the clinical course of the dengue is usually in 3 phases, where a febrile phase, critical phase, and a recovery phase. Febrile phase is usually up to 7 days, the critical being 24 to 48 hours, and the recovery phase last between 3 to 5 days. So in the febrile phase, it extends from day onset of fever to 7 days. So biphasic fever is possible during this phase of infection. So monitoring for defervescence, that is the stoppage of fever and warning signs, crucial to the identification and progression into the critical phase. And defervescence usually occurs between the 3rd and 8th day of the illness. So what are the things that you usually notice in the febrile phase is like usually patients present with severe headache, retroorbital pain, arthralgias, myalgias, rash, flushing, oropharyngeal congestion, anorexia. So when these people are subjected to biochemical tests, usually you notice leukopenia, mild to moderate thrombocytopenia, mild elevation in liver enzymes, and hyponatremia. So medical complications that you notice during the febrile phase of dengue are dehydration, hyponatremia. In case of younger children, it can lead to febrile seizures or encephalitis and aseptic meningitis. So coming to critical phase, the critical phase usually begins from at the time of stoppage of fever, but it might be as early as the 3rd day in some patients. So it can lead to severe disease in some patients. So most dengue patients usually improve during this phase, and they do not land up in severe disease. So onset of a critical phase can be identified by there will be a rapid decline in the platelet count, and there is a rise in the hematocrit value. So just prior to this, the patient might develop leukopenia up to 24 hours before platelet drop, and the presence of warning signs for the severe disease. Warning signs include third space loss, like ascites, pleural effusions, liver enlargement of more than 2 centimeters, severe abdominal pain, vomiting of more than 3 episodes within 24 hours, mucosal bleeds, lethargy, and rise in hematocrit and low platelets. So coming to how to differentiate dengue. So patients presenting with compensated shock and non-compensated shock in the case of critical dengue. So the sensorium is usually normal with shock present, but in patients with decompensated shock or hypotensive shock, there will be an altered mental status, or people might be in restless. So capillary refill is usually prolonged. Cold and clammy extremities are noted. Absent peripheral pulses, there will be profound shock, tachycardia, and pulse pressure might be variable. Acidosis is usually noted, and patient will land into oliguria and ultimately anuria. So the laboratory findings during critical phase are increase in hematocrit or hemoconcentration is noted, severe thrombocytopenia, leukopenia, and there is a decrease in the fibrinogen. So complications that you notice during the critical phase are hypovolemic shock due to plasma leak, end organ impairment, hemorrhage, and encephalopathy. So during the and once this phase is done, so people or the patients usually they enter into the recovery phase, which usually lasts for 3 to 5 days, and it depends on the severity of illness or any treatments that the patient has received during the preceding days. So, and this can be identified by sense of improvement in the patient behavior or normalcy of vitals by gradual resorption of the already leaked plasma, increased in urine output, or the patient, some patients, they tend to become bradycardic during this phase, which is normal in this recovery phase. So the manifestations include, there will be a second rash noticed during this phase, which is usually called a convulsional rash, and patients, they might present with severe fatigue. So hematocrit stabilizes, or it might be a little bit low. WBC begins to improve and platelets increases. The complications that are noted during this phase are usually because of the excess fluids that people have received during the preceding 2 phases, or organ impairment can occur in the event of a prolonged refractory shock, or it can, and ultimately which can lead to ischemic hepatitis or hepatic encephalopathy. Or people who are hospitalized, they are prone for nosocomial infections, and more prone in infants and elder patients. So if there is a cause, death in dengue is usually unrecognized without appropriate medical management, and it is usually because of prolonged shock or occult hemorrhage, fluid overload leading to pulmonary edema, shocky states, nosocomial infection, and liver failure. So coming to definition, so there has been a gradual change in the definition given by the given to dengue. So WHO usually defines dengue. So right from start is like it started WHO started defining dengue from 1997, and current definition is like for 2009. So where now currently dengue is classified into dengue with warning signs or without warning signs, and severe dengue, where usually what you notice is there is a plasma leak, bleeding, and organ impairment. So people living in or traveling to the dengue endemic areas who might present with fever and have two or more of the following features. There might be having a probable dengue, because like even before the biochemical tests are done, we need to suspect it could be a dengue. So what happens is like these are the new additions when compared to the previous dengue definition. So they can present with nausea, vomiting, rash, body pains. Tourniquet test might be positive, which is tourniquet is applied over the arm, and BP is noted. So the average of the BP, say suppose the BP is like 100/60, so it is 160/280. So BP cuff is maintained at 80 mm for about 2 minutes. So once you take it out, then then you need to make a 1 square centimeters, and if there are more than 10 petty rash, then it is positive. So patients are considered to have severe dengue if they are having any of the following, like at least 3 criteria. There should be severe plasma leakage leading to shock or respiratory distress, or bleeding manifestations, or severe end organ damage leading to like hepatitis or impaired sensorium or myocarditis. So the people at risk are pregnant women, elderly people, infants, obese people, people with congenital heart disease or diabetes, hypertensive patients, or people on immunosuppressed or on long-term steroids. So dengue can cause all these complications. It can cause seizures, encephalopathy, hepatitis, pancreatitis, myocarditis, pericarditis, rhabdomyolysis. In the eye, it can lead to macular hemorrhage, all because of the coagulopathy as part of the disease spectrum. So based on this, the differentials are usually based on, I mean, phase-wise, if you take DDs, so during the early phase, as we have discussed, there will be patients might present with just a sore throat or throat pain and fever. So streptococcal pharyngitis, the disease, rash, because of this are possible. So coming to the late febrile phase, so they might present with abdominal pain, diarrhea. So UTI or gastroenteritis should be suspected. So in case of a critical phase, patient presenting in a critical phase, usually our diagnosis should be whether it could be cholecystitis or hepatitis, because they usually present with abdominal pain or breathing difficulty or any bleeding manifestations. It might be hemoptysis, etc. So the other DDs include DKA, drug reaction, lactic acidosis, Kawasaki, malaria, and typhoid. So the clinical issues we have already discussed, like that we encountered usually during phasic dengue. It is like dehydration, seizures, neurological manifestations, shock, bleeding, worsening effusions, pulmonary edema. So what happens is usually patients before patients going into shock, the pulse pressure decreases, which is a critical thing which has to be noted, because the diastolic BP, it increases and the pulse pressure narrows before you see a profound shock. So this is an picture of macropapillary rash. So in patients with severe dengue, the liver enzymes can shoot up to more than 1,000, and there might be impaired sensorium. So this is a convalescent rash, macropapillary rash, usually seen in the recovery phase, where like there will be like white spots. Like these are islands of white in a sea of red. It is usually described that way because over a complete erythematous or a macropapillary rash area, there will be whitish spots in between. So the laboratory findings would be there will be a drop in platelets count with the rising hematocrit, as we have discussed earlier. So early identification is very crucial. Management decisions are based on that, and severity of the outcome usually depends on the presentation of the patient, existing pre-existing medical conditions, and the severity with which they present. So based on this, the patients can be grouped into three: A, B, C, where like in the coming slides, we'll be discussing about patients A, B, and C who are grouped in A, B, and C. So A patients can be sent home, B can be observed and treated, 3 definitely requires admission. So coming to group A, like all patients who do not have warning signs or does not have any coexisting conditions, medical conditions, who receive adequate volume of oral fluids, who urinates at least once in every 6 hours, who has a stable hematocrit and hemodynamics are usually kept in group A. And people with in group B are usually, they should meet at least one of the following criteria. They who have coexisting conditions, who present with the warning signs, or who are difficult to, who has challenges like who live very far away and who cannot get medical access easily. So group C people must have at least one of the following, like people who in whom there will be severe plasma leak with shock or fluid accumulation leading to respiratory distress, bleeding manifestations, and severe any organ impairment or altered sensorium. So group A patients can be discharged home after seeing, and they should be advised of daily follow-ups starting from 3 days after the symptom onset until the end of the phase 3. So in this period, we need to what we need to do is like we should tell them about the warning signs of the dengue and medical complications that can occur during this period, and we need to ask them to look for it. So CBC and hematocrit are usually sent. So any patient with group A, they do not usually require steroids or any antibiotics, or they should not be put on any anti-inflammatory medications, NSAIDs. So group B and C patients usually require hospital monitoring and treatment because the hemodynamics are affected here. Frequent hematocrit monitoring might be required, or some people might be requiring IV fluids, or monitoring for occult bleeding, or or the need for blood products transfusion, or correction of any acid-base status or hypotension. So hematocrit monitoring is used to evaluate the degree of plasma leak. If the dengue patient has a persistently high hematocrit with an unstable vitals like tachycardia, low and narrow pulse pressure, metabolic acidosis, usually fluid replacement therapy is indicated. So stable hemodynamic patients with good adequate urine output do not necessarily require any IV fluids. So they can be closely monitored and repeat hematocrit can be done. And based on that, the decision for him to discharge can be taken. So if a dengue patient usually presents with decrease in hematocrit with unstable vitals, it can indicate a major hemorrhage and a need for which mandates an urgent blood transfusion. So stable hemodynamic status with adequate urine output, it usually indicates in these patients indicate hemodilution due to resorption of the already extravasated fluids. So in these patients, IV fluid should be discontinued because it can otherwise continuous administration of IV fluids in these patients can lead to fluid overload states. So urine output should be at 0.5 ml per kg per hour should be ensured during the critical phase. If the patient is overweight, the amount of IV fluids that are required are should be administered based on the ideal body weight. And reduction in the IV fluids should be done, should be given if the rate of plasma leakage decreases at the end of the critical phase. So any patient presenting with dengue with warning signs like narrow pulse pressure or raised hematocrit. So for them and in shock. So these patients should be given a isotonic crystalloid. There is no differentiation between ringer lactate or normal saline. So a 7 to 10 ml per kg bolus is given for 1 hour and see, and we need to look for any improvement. If there is an adequate improvement, then the IV fluid is titrated to 5 to 7 ml, 3 to 5 ml and 2 to 3 ml over the next 6 to 10 hours. So if there is a significant improvement, so then fluid has to be stopped over the next 24 to 48 hours. In case there is no improvement and there is a persistently raised hematocrit, so we should suspect there is a further leak of plasma, and in these patients they should be given 10 ml of crystalloid or colloid based on the situation. So if there is an improvement, then IV fluids has to be reduced to 7 to 10 ml per kg per hour for the next 1 to 2 hours. If the hematocrit is less than 45 in these patients, in spite of giving a initial 7 to 10 ml of fluid bolus, so in these people, we should suspect there could be an occult bleed and blood transfusion at 10 ml per kg, whole blood, or a packed cells at 5 ml per kg is usually given. If in spite of this, if patients are not improving, we should suspect that the patients have got refractory hypotension and it is time to start them on inotropes and consider them as group C. So the any fluid that is administered should be, it is usually given as a maintenance fluid, and the deficit also has to be corrected. It is a 4-to-1 rule, or it can be given as 100 ml per kg per day, or and for the first 10 kgs and the next 50 and then 20. So in patients with severe dengue with compensated shock, where the pulse pressure is more, the patients are hypotensive, and there is a raised hematocrit. In these patients, the initial bolus is 10 to 20 ml per kg, than 7 to 10 ml per kg for over, and it should be given over 1 hour. And look for any improvement. If the patient has improved, then the fluids has to be given over the next 10 hours at titrator levels, at reducing titration levels, and ultimately stopped over the next 2 days. If there is no improvement and hematocrit is still high, then suspect capillary leak and give another bolus of 10 to 20 ml per hour over 1 hour. If improved, then reduce IV fluids from 10 to 20 ml per hour to 7 to 10 ml per kg for 2 hours, and the table and the rest has to be followed. If there is no improvement, then blood transfusion at 10 ml per kg whole blood or 5 ml per kg packed cells are usually given. In spite of this, if the patient is not improving, then inotropic support has to be initiated and managed as a decompensated shock. In patients with decompensated shock, the fluid bolus of 10 to 20 ml per kg should be given, to a maximum of 500 ml, it should be given over 15 to 30 minutes instead of 1 hour, and looked for any improvement. And the same algorithm follows, where a titrated lower levels of IV fluid administration is done, and IV fluids are stopped ultimately over the next 24 to 48 hours. If there is no improvement, or the hematocrit is still high, then another bolus of IV fluid at the same rate, at 10 to 20 ml per kg over next 15 minutes has to be given. If not, if still no improvement, third bolus is given, and then at reducing rates of IV fluids, it is continued. If the hematocrit doesn't improve in spite of the above treatment, then whole blood transfusion at 10 ml per kg or packet cells at 5 ml per kg is initiated. And you need to think about septic shock, cardiogenic shock, look for any organ dysfunction, because we have given, in spite of giving so much IV fluid, the patient hasn't improved. So we need to look for other cause of persistent acidosis, like if they look for any hemorrhage, occult hemorrhage, or ongoing losses. So when to stop IV fluids? So when the BP normalizes, or when there is an adequate perfusion, or when the hematocrit decreases, or when the patient becomes apyresic, without a fever for about 24 to 48 hours, or when the abdominal symptoms resolve with improving urine outputs. The indications for platelet transfusion is only in case of severe bleeding, or prophylactically it can be given if the platelet count is less than 10,000, or in case of any surgery. So management of severe hemorrhage is usually identifying the source of bleeding and stopping it. If it cannot be done, then 10 ml per kg of fresh whole blood or 5 ml per kg of packet cells should be transfused, along with other measures like controlling GI bleeding with the H2 blockers or proton pump inhibitors, or recombinant factor 7 infusion. So in convalescent phase, the IV fluid should be discontinued. The patient is getting better, because in order to avoid volume overload. In patients with pleural or pericardial effusion ascites, fluid overload may occur, and hence diuretic therapy has to be initiated. Hypokalemia is a common electrolyte abnormality usually noticed during this period, and it can be due to diuresis, and it should be corrected. Bradycardia can be noticed. So the IV fluids, if the initial IV fluid boluses which we have discussed, 10 ml to 20 ml per hour, 20 ml per kg is initially given if it is patient is not improved, and we have given we can give dextran or colloids usually. So along with this, a diuretic is usually given, because hyperosmolar colloid usually it draws blood from the third space, and diuretics, it will help in reducing the intravascular volume, ultimately helping us to decrease the intravascular volume. In patients presenting with encephalopathy, so the total IV fluid shouldn't be calculated, total IV fluid shouldn't be more than 80% of the maintenance balance. And switch to, instead of crystalloids, colloids has to be given if hematocrit continues to rise in spite of a large IV fluid boluses. Diuretics, head end elevation to, neuroprotective measures, avoid hypercarbia, early intubation, steroids, maintaining sugars between 80 to 100, electrolyte, any corrections, vitamin K administration required, anticonvulsants if the patient seizes, antibiotics if the patient develops any secondary infection, proton pump inhibitors, or ultimately any continuous renal replacement therapy. So coming to diagnostic testing. So in the initial 5 days, there are different diagnostic tests available, like antigen and NS1 antigen. or an IgM or an IgG specific to the dengue virus. So the initial period, during the initial period, NS1 is more specific. Then comes IgM and then comes IgG. So IgG dengue ELISA is not present early in the, I mean, if the patient is getting a dengue virus viral infection for the first time, it is usually not detected. So IgG dengue antibodies is cross-reactive with from other flavivirus group. In summary, like regarding blood test, the viremia coincides with the fever, with the peak of the fever. So blood drawn during this period can lead to high rates of positivity. IgM antibodies can last up to a maximum of 30 days or usually till 60 days. IgG antibodies are detected for life for a specific serotype. Or IgG is positive throughout. Coming to prevention of dengue, so there are two vaccines that has been developed to treat dengue or for prevention of dengue or to tackle severe dengue. So it is the first vaccine developed is Dengue, which is approved in Brazil, Salvador, Mexico, Philippines. But its usage is restricted due to lack of efficacy against serotypes 1 and 2 and relatively risk of severe dengue in those with the seronegative individuals. So this vaccine should not be given in people in whom dengue virus, I mean, who have never suffered from dengue infection. Another vaccine, Qdenga, has recently been approved in UK, Europe, Indonesia, but it is no effective or it has shown no efficacy against strains 3 and 4. So, basically, ultimately, when we come to preventive measures like vector control measures has to be taken, like elimination of Aedes larva, or clearing mosquito breeding habitats, or genetic engineering of Aedes mosquitoes, or infecting the female mosquitoes with Wolbachia bacteria. So there are, I mean, if you come, there are 4 S's in dengue, like search and destroy the mosquito breeding places, secure self-protection from mosquito bites, seek early consultation when signs and symptoms of dengue are noticed, and say yes to fogging. So people who are planning to travel to the dengue affected areas are usually recommended mosquito repellents like cardin, oil of lemon, eucalyptus, and other things. And use of permethrin is usually restricted to the clothing rather than, and we are not supposed to apply it to the body. So, in nutshell, assessment when you're suspecting a dengue, like people traveling or anybody presenting during the epidemic phase with nausea, vomiting, abdominal pain, rash, or warning signs, or leukopenia or tourniquet test positive. So, or these people who are without warning signs are usually grouped in A. Those with coexisting conditions like pregnancy, infancy, or any aspect, renal failure, elderly people are kept in group B with warning signs, and anybody who is in respiratory distress due to pleural effusions or severe bleeding or severe organ impairment like liver, kidney, or neurologically are grouped in C. So coming to the do's and don'ts of dengue, so do not use corticosteroids. They're not indicated and can increase the risk of bleeding. There is no indication of routine platelet transfusion. Half normal saline should not be given, ideally. So do not, unnecessary administration of IV fluids is not recommended. Treat the shock early. So with these people, I mean, we have already mentioned this in the earlier slides. So patients with group A are usually advised to take a paracetamol for a fever control or do tepid sponging, hydrate enough, and prevent the spread of infection or virus to other members of the family, and look for warning signs, or look for warning signs, and or else look when the temperature reduces, so that that means they are going into the critical phase. So these are the slides in nutshell which we have already discussed. So those in compensated shock, and the next slide comes with those in full shock. IV fluid administration. Thank you, everyone.
Thank you, sir. That is very nice and descriptive presentation. Coming to questions, as of now, no questions were posted. Coming to today's topic, one thing we have to know that when to give and when not to give the fluids. IV fluids are definitely necessary, but when to give and when not to give, you should know that as an ER physician, definitely. And roll of blood emissions, it should be known. And we have to check for warning signs like bleeding, rashes, and signs of shock like tachycardia, hypertension. These to be definitely noted. Regarding that, admission and process will be continue. And we should look for coagulopathy signs, and definitely we should note for pulmonary one, because the common method is giving continuous fluids, heavy fluids will be given, and we will miss the pulmonary picture generally. So we should note for that, and we should check continuous hydration status, everything. And another thing I like to repoint this. There is no role of steroids in dengue shock. Okay. And coming to vaccination, still there is no clear documentation is there. But in pediatric age group who have previous infection, and some other endemic areas who patients going to endemic areas, vaccination can be done. That should be known further. Okay. Until now, no questions are asked, sir. Anything about from your side? From your side, sir?
I don't like to add anything. I mean, most of the things are covered. So, and one more thing is, like, there are recent studies coming up. So these are still in the preclinical trials. So the thing is, like, the virus is usually what happens is, like, endoplasmic reticulum in macrophages is most vital organelle or cell organelle, which is very much essential for the replication of the virus and further transmission. So newer studies are trying to target the use of antivirals, whether they are thinking about use of antivirals in dengue. So that can target the endoplasmic reticulum, but it is still in the very early phases, like it is still in the preclinical trials. So there are few studies on that. So, but nothing has come out yet.
Okay, sir. Thank you so much. Shall we conclude, sir?
Yeah, sure.
Yeah.
Thank you.
Once again, thank you, Srinath sir. Thank you, Kiran Kumar sir. Thank you, Vinay sir, and all our HODs for giving me the chance. That's all. Thank you.